Hello, I'm Michael Pierce, and this is The Human Condition. Welcome. Today, our topic is alternative approaches to long COVID. This is a big deal for so many people, and I can't say that we haven't seen it before. I'll explain in just a moment. What we'd like to do today is unpack some of the assessments and mechanisms of what might be going on for people with long COVID, and to also explore some alternative approaches. I have to be careful in that particular vein because there is the threat of the discussion of fraud. And so in medical fraud, there is a worry that's legitimate, which is that if doctors think independently and think freely, and they go against a particular line of reasoning or a particular convention of a certain group of people that establish the standard of care, that somehow that's automatically fraudulent. And actually, it's really an exercise of freedom. And many times it is a way of breaking out of a cabal of actual monopoly and control of a practice of medicine. So unfortunately, there are some powers that want to focus all of the assessments and treatments and codes and reimbursement on one particular narrow method of intervention, which may be jabs or may be medications or maybe hospitalizations or maybe ventilators or maybe a number of things. And there may be some value to all those things. And I accept that. However, we all need to be held to the same standard, which is let's prove what we're doing and study what we're doing. Let's have funding to do that. And let's also make sure that the risk benefit ratio is favorable. One of the great wonders about alternative medicine is that the risk benefit is extremely favorable. If you're dealing with something that isn't terribly lethal, and we know that the numbers are clearly in, they started with the Diamond Princess cruise ship, which was very early on, and now they've progressed to some very definitive studies, which I'm not going to dive into here. We don't have time, but there's been a number of definitive studies after the fact that have shown that 3 and 4 years later, we have a very low mortality rate for all but very, very small groups of people. And that's not to discard those people, but that's to explain that for most people, this is not a highly lethal disease. So if that's the case, then we don't have a danger of trying something that's alternative. So that lowers the risk. We also know that the alternatives don't carry with them inherent risk of harm. So you're looking at things that are extremely nice and gentle and innocuous types of alternatives that include diets that eliminate certain foods or that add certain foods, things that include other foodstuffs like herbs and vitamins and minerals, things that might include binders that detox people, and methods that might include neurofeedback and EEG and ERP methods that measure the brain. Also, a number of lab tests. Certainly, a number of those lab tests may be standard medical tests, and some of them may be a little more alternative in that they might be urine or hair, and they're less accepted as diagnosing standard pathology, but there's still measures of physiology that are very strong and that are represented in the literature. So what I'm trying to say is that I think that there needs to be room for people to be more flexible. Now, let me give you just a little bit of history. A lot of people and a lot of media, when the virus hit, started saying things like, wow, loss of sense of smell or loss of sense of taste is a new thing, and it's a hallmark of this one new virus. And that's not true, and it's never been true. It's been to doctors that treat patients that have all kinds of problems like rhinoviruses and other types of difficulties that happen in their sinuses and their upper respiratory tract. Wherever you stand on the whole viral theory, it doesn't really matter. The point is that when people get sick and they get symptoms, there is a long history of people losing their sense of smell and sense of taste temporarily from a chronic or from an acute episode of a fever and an infection and a type of acute syndrome where they get lots of mucus production and lots of sneezing and coughing and catarrh or mucus, where they also have maybe headaches, maybe fever, maybe sore throat, maybe they get strep or staph or something. We don't, it's not necessary to nail down which one, but it's any of the class of upper respiratory symptoms. They get these problems of mucus production. And so they often can lose the sense of smell and taste as the mucus is released in their sinuses. Now, one theory of this is that they lose zinc, because zinc is extremely important in the immune system for fighting viruses and bacteria. And it's believed that often people are low in zinc when they get sick, and they lose even more zinc as they fight off an infection of any kind or as they have a fever. Now, even others suspect that it may be more toxic related, that a person may have heavy metal toxicity or they may have zinc deficiency, and that really peaks. That deficiency either actually troughs, it goes to the bottom, and that deficiency really hits bottom, and then they lose their sense of smell and taste because these are highly dependent on zinc receptors that are zinc dependent in the brain and in the nose. That's one set of mechanisms. We also know that smokers that smoke cigarettes or that chew tobacco over time deplete their vitamin C reserves and they deplete their zinc reserves. And so it's very common for them to have a loss of taste or smell after years of smoking or years of chewing tobacco. And then when they quit, it often comes back within a year or two. And in fact, a lot of their lung function comes back within a year or two, which isn't a very popular statement, but it does happen that they return their function. And I remember growing up in the 70s and seeing a lot of people that smoked. And I remember being involved in rooms that were just filled with, 3 feet from the surface of the ceiling was just clouds of smoke from everyone smoking indoors and in elevators and in rooms and in offices and homes and even airplanes. So this is a thing that we all live through, and we're not dead yet. So I think that fear is something we've got to look at. So this idea that a person can get a zinc deficiency from any number of things, and that can come from an acute infection, it can come from chronic infections, it can come from smoking, it can come from just deficiencies from eating foods that are binders. We always talk on this channel about anti-nutrient foods like lectins and oxalates and phytates and all those different things that can bind to the foods and carry them out of your stool. There is another syndrome that I talked about or in other lectures called chronic viral syndrome or post-viral syndrome. And post-viral syndrome has been known about since long before the virus. And that was the idea that when a person has a chronic infection or what looks like a chronic infection, it could be chronic toxicity, it could be chronic infection. We don't really know. It could be a weakened state. It could be heightened mucus from continuing to eat mucus producing foods. Think about this for a second. If you never ever knew that you were eating mucus producing foods and that you were deficient in certain nutrients and you had a mucus producing gut and a mucus producing sinus and a mucus producing ears, and you were eating foods that were continuing to trigger your immune system to produce low-grade mucus, which is known. This is actually in textbooks on lectin science. It shows that the first things that happen into the gut lining when a person is exposed to lectins is that they get a lowered pH, which causes disruption of the gut barrier. So they get leaky gut, and those cells become pulled apart. And they also get mucus production. So mucus production and lowered pH or acidic pH, those are well known and they're written about in textbooks on lectin physiology. So when a person has a chronic viral syndrome, it's possible that maybe they're not just infected by a virus that keeps coming back and kicking their butt, like happens in Epstein-Barr virus or happens in other viruses. It also happens in a non-viral syndrome like Lyme disease. And again, I'm not trying to say that all Lyme disease is not caused by infection and all viruses are not caused by infection. I'm trying to stretch your mind and have you think like a clinician, which is what if the person's problem was driven by having all of these mucus producing foods? And the reason I say that is I've had the pleasure and joy of helping take people off of mucus producing foods and seeing that these chronic viral syndromes lift and that the mucus goes away, the postnasal drip goes away, the ear wax reduces and the clogged ears. And when I look in ears with an ear scope, with an otoscope, and when in the eyes with an ophthalmoscope, we see changes that happen. We see in the ears, we see particularly a loss of fluid in the eardrum. When you look in a healthy ear, you see the drum and it's a clear membrane that you can see through. And in a perfectly healthy person, behind that eardrum should be clear. It should be empty air. And that chamber that you're looking in, as I look in there, I should see the drum and I should see behind it the ear bones, and there should be no fluid in there. There should be no pus. There should be no redness or whiteness or yellowness or clear water. There should be air, just air. And I should see that there's a chamber there with 3 bones. The malleus, incus, and stapes, right? The hammer, anvil, and stirrup sitting back there. And if I see fluid, but I don't see redness, I can't diagnose that person with middle ear infection. I can't diagnose them with otitis media because they don't have redness, they don't have swelling, they don't have any kind of confirmed signs of infection. But they have a non-typical ear. They have an ear that's filled with clear fluid or yellowish fluid that's clearish or cloudy. Or then it gets a little bit milky and it becomes a bit white. And then at some point it becomes yellow. And once it's become yellow or red or green and there's swelling, then we can call it an ear infection. But until it's an ear infection, it's what? A pre-ear infection? Well, there's no diagnosis code for that. So what do you call it? My belief is that we have lots of people running around that have these chronic viral syndromes and chronic bacterial syndromes and chronic spirochete syndromes, and they're fostered by these mucus-producing diets. Now, if you were to consider that mucopolysaccharide is mucus and sugar, and when you eat a food that makes your body produce more mucus and sugar from your own tissues and mix it with water and put it on the surface of all your membranes, you're basically laying out a soup that invites anything to come and infect you. You're basically saying, come here and eat this wonderful fuel, eat this sugar, eat this mucopolysaccharide because it's exactly the kind of fuel you need as bacteria or viruses or fungi or spirochetes. Come host and just, munch away on my tissues, my mucous membranes, my ears, my throat, my tonsils, my gut lining. Just welcome. Come on in. Does that sound smart to you? It doesn't sound smart to me. So one of the things I want to do is I want to starve those little buggers of all that mucus, which means I want my patient on a mucus-free, what they used to call a reduced catarrh, because CATARRH was the name for mucus. And in the old textbooks, you'll find that in the very old medical textbooks, they refer to mucus with several different names, phlegm and catarrh and different kinds of humors. They have different kinds of humors that they call this. So the idea, the concept is, let's get them off of that mucus, because sometimes they get fevers. Now, let me ask about fevers. Has anybody ever heard or seen in a textbook that a fever could be caused by a toxin? Is a fever always caused by an infection? Well, sometimes it is. And sometimes when we have an infection, we have elevated antibodies or elevated titers or even elevated cultures of bacteria like strep and staph in our throats. And we have elevated Marcon's tests in our nose, which is bacteria and viruses. The Marcon's test is a swab that we stick up the nose, very similar to the COVID test that's stuck up the nose. Only this one is a culture where you get the stuff out of the nose and you rub it in a petri dish and you grow it for a month, and you look at how the viruses and bacteria might grow in that culture, and fungi rather, mostly fungi and bacteria. And so that's the idea of what you're doing with the Marcon's test. You can have that happen anywhere in your body selectively. Some people have it more in their throat, some more in their nose, some more in their ears, some more in their chest or upper lungs, some in their bronchi. I have a number of people that have chronic asthma. So we have to ask ourselves, are these lung syndromes just related to a flare of a virus or a flare of a bacteria, or are they more related to your diet and your resilience and your lack of sleep? So when we're looking at long COVID, we have to ask ourselves, does long COVID reveal some news to us that's telling us our body is not in the shape that we need it to be compared to other people that are well? And that's not an indictment of you. That's not a guilt statement. That's not a shaming. That's a statement of fact that the body is trying to tell you, because it can't write you a letter. So it tells you in what I consider quite clear language that says, hey, you're not doing what the rules are of physiology. And while I don't make those rules, they're sometimes unfair to a lot of people, and they may not be the same for everyone because we all have different genetics. Some of us are much more subject to lectins than others. And so because of your biochemical individuality, you may be extremely susceptible to eating beans or snap peas, and other people aren't because of the lectins or other anti-nutrients. So while that's unfair, I can comfort you and say, yes, it's unfair, but now let's move on and let's figure it out. And if an elimination diet's the only way to know, because there aren't any lab tests for lectins. You can test antibodies for lectins, but that doesn't really matter because the lectin doesn't need an antibody to bind to your sinus membranes or your mucous membranes from your nose to your toes. So that means that you can only do an elimination diet as a scientific experiment to see if this is the case until someone develops a lectin test that you can use to find out if your body is sensitive to lectins, and that may be coming. The idea that long COVID is a chance to reveal what your weaknesses might be could be something else. So let's walk down that something else. Let's walk down that list. I've already talked about mucus producing foods. I've already talked about toxins. That would be chemicals, that would be heavy metals, that would be molds. Those are things that can cause a person to spike a fever. And it would also make them test positive for antibodies in many cases, because inflammation triggers the immune system, and the immune system will react to anything that's around. And so you might have antibodies that are positive for bacteria or viruses, and they may not be the causative agent. They may be a result of the person's imbalance and lack of resistance, lack of hardiness, lack of tolerance to their environment. Further, they might have something else, which is a tolerance problem that has to do with their thymus gland. Now, your T cells are regulated by your thymus gland, which is right behind your sternum. And in certain cultures that eat healthy diets of all types, largely meat-based diets around the world, but many of them are plant-based, and they have good exposure to the sun, they have a nice, robust thymus gland, which is an immune gland, living behind their sternum well into their 60s, 70s, and 80s. But Western societies, when you dissect people and open up their chest after death, you find out that their thymus gland has atrophied, and it's reduced quite a bit. And that relates to how our T cells are. So it's possible that a person may need more nutrients for their thymus gland, and that would be the fat soluble vitamins A, D, E, and K. The literature is very clear about that. We also know that saturated fat is extremely important for the thymus gland, and we know that light is extremely important. There's an entire subject of decentralized medicine that I'm excited to tell you about that's working on the system of red light frequencies and comparing it to blue light frequencies and UVB light frequencies and all of the melanocortin and opiates that are in our bodies, the natural opiates that are in our bodies that help us with pain control. And so it's entirely possible that a person is sun deficient, solar wave deficient, and they're jacked up on blue light from their computers and their machines and their screens and their phones and their light bulbs in their house, and they're exposed to too much of the wrong wavelength at the wrong time and not enough of the full spectrum of the sun. And sometimes parts of this can be made up by other light therapy and bulbs and arrays of lights that can be shined on the belly or the thymus or the brain. But really, the best therapy would be light therapy of the sun, getting out into the sun. So you may notice a common theme here, which is I'm not talking about fighting viruses. I'm not talking about looking for an antiviral herb or an antiviral element like silver. I'm not talking about trying to kill viruses. I don't believe anymore that we need to kill or go to war against infectious organisms. I think that the living system really needs, even in cases of gangrene, very advanced cases of gangrene, like in the Civil War, when someone gets a wound and the doctors have to decide, man, should we amputate that leg or should we amputate that hand? Because they've got gangrene. And if we don't deal with the gangrene, we're going to have them get a septic infection, and they'll get sepsis, which is an infection throughout their blood, and their whole body will die. Well, there's a whole host of doctors that we don't have time to talk about today where they have looked at people and done things like whole body systems of treating them with sunlight, treating them with ozone, treating them with oxygen, treating them with a peroxide. There's just a number of ways of treating the whole person and trying to put them in electric fields like med beds and different things to try to help them get better and not have to amputate their limbs or their teeth. Because really, when you lose a tooth or you have a root canal, it's an amputation. You're losing a limb. And I don't know about you, but I don't want to lose any limbs, especially in my face. So the idea is that long COVID gives us a chance to take an inventory and figure out what have we been missing. Our body is telling us in a either a gentle way or it's kicking us in the butt saying, man, you need to look at these issues. And if you continue to use your conscious mind to have a narrow band of, I need antibiotics or antivirals, I need medication, I need drugs from pharma. And that reminds me of the new movie, First No Farm. It's very important. Asim Malhotra has produced this movie. It's extremely exciting. The idea is that you're not deficient in drugs. We weren't put together to be deficient in drugs, and certainly drugs could be very helpful in a life-threatening situation. But I think it's unfortunate that chronic infections are considered something that the first line of defense would be drugs. I think the first line of defense against chronic infections would be detoxification, dietary anti-nutrient elimination diets, replacement of deficient nutrients. I think it would be toxin testing. I think it would be solar exposure and sun exposure in a judicious way. And I think that it would be a whole bunch of lab tests and studies of the health of the gums and the teeth, the ability to get all the different wavelengths of light. And I think that we also would want to do a couple things. There's not a very good test for aluminum right now. So one of the first things that I like to do with people is to give them a trial of some kind of silicic acid water. I like to say, look, let's try some kind of water, like Fiji water is an example. It's not the only one, and it's got some problems, but the general idea is that Fiji waters and some other waters in the world that have silicic acid, which is dissolved silica in them, can go into the brain, cross the blood-brain barrier, grab a hold of aluminum and pull it out of the brain, pull it out of the blood-brain barrier safely, carry it to the kidneys, and carry it out of our urine. But since there's no great accurate test for aluminum that works reliably, we can test urine for aluminum, we can test blood for aluminum, and if it's high, that's great, and we should pursue it. But most of these tests are not accurate. So that doesn't mean we don't do them. It just means that we don't assume that they're, we assume a false negative. And so it's pretty simple to use. The protocol is about 1 to 1.5 liters per day of some kind of silica water that has at least 30 parts per million, 30 milligrams per liter of some kind of dissolved silica or silicic acid. We're not talking about just a silica herb, because that's going to work great in the gut, but it's not dissolved into silicic acid, so it's not going to cross the blood-brain barrier and grab the aluminum that's messing up our brain. So it'll be great for the gut, but it won't be great for the brain. So that's another thing that I want to do with everybody that's got a long COVID is say, hey, have you done this? And you might ask me, well, gosh, Pierce, that's crazy. Why would you give somebody a treatment for something that you don't have a good test for? And I'd say, well, where does aluminum come from? Well, it comes from antiperspirants, antiperspirants that can contain aluminum. It comes from jabs, because jabs have an adjuvant in them called aluminum, and there's many, many kinds of proprietary aluminum. They're industrial secrets, and we're not allowed to know their formula, and we're not allowed to look at those. And so that's something that we're not allowed to understand, and they're proprietary, but they're aluminum. And so we need to assume that those are in many of the jabs that we've all taken. We also need to know that aluminum is in pots and pans and food and aluminum cans, and it's also in glyphosate. It's in a number of pesticides and herbicides. It's in chemtrails, and it's been measured to be descending on us when weather patterns are interfered with by various types of sprays in the sky. So that's been established. The science has been established on that. We know that aluminum, we live in a sea of aluminum. So if you haven't studied that, please study the work of Jack Kruse for the light. Please study Dr. Alexis Cowan for that as well. There are many more doctors that are just fantastic at this than I am. Please study Christopher Exley regarding aluminum and Dennis Krause regarding aluminum and his book Silica Waters. So when you've got a particular type of long COVID, you really need to look at all the possibilities that might be missing. I like ketogenic and carnivore diets. I don't think they're the end all and be all, but I think that nudging a person from a very carbohydrate, very processed food based diet towards a more keto or ketovore, carnivore diet makes a benefit, even if you don't make it all the way. I don't think that you have to be strict to receive a benefit. And I, in fact, believe that all of life, from the moment you're born until the day you die, is a journey, and that everybody, including me, is learning what is the best thing for me. And so that's always changing. It's always modifying. I think that it's always getting better, and you're always learning more, and you try stuff, and you go down a road, and you go down a rabbit hole, and you try something, and you say, well, that wasn't for me. And other times you try something and you say, man, I'm going to adopt that for the rest of my life. And then other things you adopt for a short period and you give up and you don't need them anymore. But what I would encourage everyone to do is look at this as a nudge. Every single day you make new decisions and you try new things and you see how your body is doing, and you talk to other people that have done it, or you talk to people like me that have done it with thousands of other human beings and have lots of experience managing those cases, measuring the blood work, examining people, doing physical examinations, and making physical assessments and diagnoses on people to try to understand, what does this mean? And I have to tell you, I've seen a lot of people get better from a lot of chronic diseases. And most of us are really locked into this idea of very narrow healing. We don't understand that we can heal from amazingly awful things, from a very, very bad place. And I've seen some amazing things get better from from autoimmune diseases to chronic infections to cancers. You know, in my lifetime, we're going to see people growing limbs back. And I haven't seen that, you know, in my lifetime other than starfish, but you're going to see that happen in my lifetime. We're going to see growing back of limbs. But regardless of growing back of limbs, people have overcome horrible advanced cancers that are, you know, golf ball sized brain tumors, people that only have 3 weeks to live. They've done things like Brzezinski's work, Stanislav Brzezinski in Texas with anti-neoplastons. We've seen people recover from horrible autoimmune diseases, from diabetes, from bone diseases, from joint diseases. We've seen people recover from awful obesity. Heart disease is a little tougher, but we've seen a lot of heart disease recovery. And kidney disease is almost easy now, along with liver and pancreas problems and even pancreatic cancer. So I just want to give you some hope. I want you to understand that while I can't give you pharma level research, really neither can they. And I think that you're going to see in the next few years conditions like long COVID be studied with regard to large population studies. We're going to see placebo-controlled and non-placebo-controlled studies. We're going to see retrospective studies of large numbers of populations. And we're going to see lots of comparisons about differences between the jabbed and the unjabbed. I think you're going to see a lot of hope and a lot of promise in the future. And I'd like to be there with you.